Okay, so I just want to check in with everybody really quickly. Does anybody have any questions or concerns about the material at this time? We have, I don't know, probably 7 or 8 slides left in the alcohol lecture. We'll probably wrap that up about halfway through today's time, and then we're going to move on to general anesthetics. So that's kind of our to-do list for today. Before we left, we had been talking about kind of different consequences of alcohol consumption and how there are kind of resulting effects, especially in the central nervous system, that can be treated with IV thiamine. So somebody kind of left off kind of asking, well, can you take a supplement of thiamine? Is that a possibility? It is a possibility, kind of after doing kind of general search online. I did see that there were some instances in which thiamine was prescribed, but I did also find in some instances some current research that was being done in order to look at if this was an effective long-term treatment strategy for those who have alcohol use disorder. Just really quickly, again, I think maybe I'm going a little overboard on the hyperlinks in the PowerPoints, but I did find this particular link pretty interesting and useful. So if you're interested about the role of thiamine in the alcohol brain disease, I just thought that this was a really nice synopsis, just kind of answering questions about the consequences of thiamine deficiency. And then that we had talked about Wernicke's encephalopathy and Korsakoff's psychosis. And so again, it just does a nice job of outlining each one of those and the effects that it has within the brain. So if for some reason you're very personally interested in this particular process of thiamine and the brain and kind of the effect of alcohol in the brain, this could be a very interesting website. So just go ahead and check it out, and I'll make sure that after we finish this lecture today, I save this particular link and upload it to Moodle. So there is some interesting material out there. Like I said, I did find actually a clinical study that was focused on the use of thiamine as a supplement to treat chronic use of alcohol. So again, just a good question and worth expanding upon. So that's, again, Korsakoff's and Wernicke's are one example of an effective chronic alcoholism, but there are a ton of other ones. So if you read the chapter, what I have put onto this slide is probably a good chunk, not a good chunk of the chapter, but it's a very long laundry list. So first of all, we'll talk about neuroendocrine effects of chronic alcohol use. So in the introduction for this particular section of the material, there's this kind of, I guess, part of a Shakespearean description of what happens when you just imbibe too much alcohol, and it was kind of describing the effects on sexual dysfunction. Roughly 70% of people who have alcohol use disorder are going to have some type of sexual dysfunction, whether it be in males or females, both instances. In terms of the neuroendocrine, it's going to essentially affect calcium absorption to the bones. Calcium obviously is an important cofactor for calcification of the bones. It aids in bone hardening. And so if you're interrupting the calcium uptake, it's going to also affect essentially bone brittleness and the ability for the bones to remodel themselves. Body temperature. So we talk about body temperature. If you've ever maybe had too much to drink and it makes you flushed, it's going to make you feel very warm. Often one of the leading causes of death can be hypothermia, because individuals feel that warmth. They go out into the cold, they don't realize how cold they are, they don't maybe go out with a jacket. And so this can be a major contributor to hypothermic deaths. Diuresis, again, you inhibit the release of vasopressin. It's another effect of alcohol on the neuroendocrine system. In terms of the cardiovascular system, the textbook describes kind of this J effect where, you know, a little bit of alcohol is actually advantageous. If many of you have probably heard things said like, if you have a glass of red wine each day, that's good for your heart. So again, it's that all things in moderation. So a single glass minimal effect might be positive, advantageous, but then, you know, if you hit that high point of imbibing too much, it's going to have negative effects on your cardiovascular region. So it's going to affect things like serum lipoproteins. It also can increase hypertension. So if you are a chronic alcohol user, it's going to raise both your diastolic and systolic blood pressures, and then can also affect cardiac arrhythmias and cardiomyopathy. Similar to what we saw with the cardiac studies, stroke, again, low concentrations can be found to be beneficial, but then if you're imbibing up to 40 to 60 grams a day, you're going to have an increased risk of stroke. It's going to affect the alveolar functioning of the lungs. And in skeletal muscle, you see decreased muscle mass and strength over time, again, this is seen kind of chronic alcohol use. And so many of the effects that we're seeing here are side effects seen with AUD or chronic alcohol use. In the GI tract and esophagus, you'll see a lot of cancers associated here. So you can see esophageal cancer, liver cancer, pancreatic cancer, but it'll also lead to reflux, esophageal reflux. It will also eat away at your stomach lining and cause acute or chronic gastritis. Diarrhea is a side effect of this as well. Can cause pancreatitis, either acute or chronic, and then not surprisingly, it's responsible for roughly 50% of liver disease and also liver cirrhosis. Again, this is kind of a very abbreviated list of these things. There are expanded descriptions of them in the textbook, but we could probably spend an entire lecture talking about each one of these disorders in its entirety. And I kind of alluded to the fact that cancer is also an outcome of this. So oral, pharynx, larynx, esophagus, colorectal in men, and breast in women can also be a result of chronic alcohol use, or there's some correlation with chronic alcohol use. Okay, so in terms of the clinical uses of ethanol, so we talked a little bit earlier kind of about how there is a similar enzyme that's targeted by both ethanol and methanol. So because of that, you can use the alcohol dehydrogenase, you can use ethanol to treat methanol poisoning. So you're competing for that enzymatic function. Dehydrated ethanol can also be injected into the trigeminal neurogliar for pain. And then also this, if you wanted to treat epidural, subarachnoid, and lumbar paravertebral injections are given for inoperable pain. So again, it's also used as a pain reliever in some instances. Okay. I'm going to pause. Any questions? Okay. So when we move on to talk probably something that's more pertinent to you are things like drug interactions. And so drug interactions, I think it's always going to be important when you're using a depressant to think about the use with other depressants, other things like benzodiazepines. So it is going to obviously have a synergistic effect with those. And so you can get increased, we talked about this last class period about how you can get an increased effect at lower dose concentration. So if you are, let's say, on a benzodiazepine and you imbibe an ethanol, you're going to kind of lower the threshold for those higher dose effects. So things like coma, sedation, you could achieve that at a much lower dose if you have two depressants kind of essentially working together. Acute administration can also affect functions of enzymes that metabolize things like codeine, morphine, phenyltonin, and some benzodiazepines, as well as warfarin. And then chronic administration is essentially going to increase CYP2E1 function. So if you're chronically using, again, the enzymes that have to metabolize that alcohol are also going to become upregulated. And because of that upregulation of those enzymes are not just specific to alcohol, but to other types of drugs are also going to increase the rate of metabolism of those other drugs. So in this case, we see increased rate of metabolism of that phenyltonin, warfarin, propranolol, as well as benzodiazepines. So those other drugs that are metabolized by that CYP2E1 are also going to be broken down at increased rate because you have more of that enzyme present, or the upregulation of that enzyme that's trying to process that ethanol. Okay, so in terms of comorbidity, this was originally, I think, characterized comorbidity with other disorders, but this is focused on comorbidity of mental health conditions. So there is, like, in the literature a ton of information showing comorbidity with things like depression and anxiety or other mood disorders. People who suffer from these mood disorders are 2 times more likely to suffer from drug abuse disorder, things like AUD. And in terms of post-traumatic stress disorder, it's basically estimated that rates could be as high as 30% for alcohol use disorder. And there's some neurochemistry just showing some overlap in terms of the areas that post-traumatic stress disorder affect and how there are areas in which might be becoming overactivated and how ethanol might be able to depress those regions. So it's almost like a self-medication effect that can occur in some individuals suffering from post-traumatic stress disorder. And because of that, you see that positive reinforcement that we talked about last class period. Again, that positive reinforcement is going to reinforce the dampening of those regions that maybe are overactive in post-traumatic stress disorder. So alcohol use disorder is going to be influenced by culture, not super shockingly. So last time we heard about kind of the culture that is in Japan with business folks, how you have to imbibe in order to, be successful in that area. And I think that might seem like an extreme version, but I mean, if you think about even the cultures that we have here, the college culture, I think is another place where you see kind of a lot of obviously ethanol intake. And so this disorder can definitely be exacerbated by someone's environment. But with that, taking into the account that, it's kind of, there's always that 2 branches of the tree that's influencing an individual. You have your environment and then you have your genetics. There is some evidence that there's at least a 50 to 60% heritability or genetic predisposition to things like AUD. We did discuss some of the SNPs and the effects that those SNPs have in terms of processing alcohol, creating enzymes, if that either decreases or increases tolerance to ethanol. Other genes, other SNPs and genes that can also affect alcohol tolerance, things like the SNPs in the opioid receptor, the dopamine receptor, again, that's going to obviously alter reinforcement. Serotonin, again, another kind of happy neurotransmitter that alter reinforcement. Dopamine receptors on here twice. And then the GABA receptor and the glycine receptor, again, these are probably more direct targets of ethanol. And so any type of genetic variant within them could also alter someone's response to ethanol and either cause a positive or negative influence. Okay, so if we look at the pharmacology of alcohol use disorder, so you can see that the FDA has approved essentially 2 different treatments, disulfiram and naltrexone, and they work essentially by 2 different kind of mechanisms of action. So disulfiram is going to inhibit the ADL activity, and therefore if ethanol is consumed, the effects are going to be exacerbated. And so if anyone who is a chronic user takes this drug, if they even take an individual drink, their reaction is very similar to those individuals who have this SNP that doesn't make a functioning enzyme, not shockingly. So you're going to get the very quick flushed face. You're going to have all the very acute toxic effects of ethanol. Someone who's taking it is going to essentially take 500 milligrams daily for 1 to 2 weeks, and then your maintenance dose will be at roughly 125 to 500 milligrams daily after that. So again, this is probably the most interesting component of this to you as future pharmacists, is thinking about these drugs and how they're applied. You can see here in this simplified metabolic structure here, how disulfiram is going to inhibit alcohol dehydrogenase. If we look at naltrexone, it has a different mechanism of action. It's actually inhibiting the mu opioid receptor. This is going to focus more on, the addictive, I think, component of alcoholism, where you're going to reduce cravings and decrease relapses. Roughly, the prescription for that is 50 milligrams per day for several months. And there are instances in which this is administered in several different ways. You can get a long-lasting injection, and then outside of the US, you can actually have an implantation of this, again, to create chronic alcoholism. Acamprosat is another drug that's been shown to be slightly effective, but it has an undetermined target. Some predict that it might be glutamatergic in its function, although that hasn't been entirely characterized. It has been shown to reduce relapse, and so there is some form of effectiveness there, but is probably not as often prescribed as these other two drugs. Because of the negative side effects that you see with the sulfiram, when I say negative, I guess if you do drink, you have kind of that exacerbated acute toxicity response. It has a very low rate of, I guess, consistency within the individuals who are taking it, just because they have that, they have the low toxicity effect, and kind of it reinforces them not taking it so they can, imbibe and feed that kind of addiction cycle versus the treatment. So are there any questions about these drugs? This figure here is nice because it does show the site of action of disulfiram on the aldehyde dehydrogenase. And then it also shows formimazole as the inhibitor of alcohol dehydrogenase with methanol. But yeah, I just wanted to pause for a second and see if there were any questions. Okay, so if you don't have any questions for me, I have a question for you. Another concept check. This is basically the same concept check that we I read to you earlier. So you have this this 50-year-old gentleman who's coming in for an appendectomy, starts to show signs of alcohol withdrawal. What drugs could you prescribe long-term for this individual? So if you want to go ahead and private message me your answer, I'm going to give you just a minute or two to just go ahead and consider. So you have this person who's had a seizure. You've already administered lorazepam, given them an oral chloride dioxide. And so what other drugs could you administer long-term? Okay, so it looks like everybody's, coming up with the answer. It's kind of, I guess, not one necessarily right answer to this question, because we just kind of went over the two drugs that could be administered. So we talked about how you would administer a loading dose of the disulfiram to manage. That's often used to manage alcoholism. It inhibits alcohol dehydrogenase, And then again, if alcohol is consumed, results in adverse reaction resulting in flushing, severe headache, nausea, and vomiting. Naltrexone, an opioid agonist, is yet another drug used to manage alcoholism, which we just talked about. Again, those both could be administered to this particular individual. It looks like in some instances, people suggested you could use an naltrexone with the acamprosate as well. Somebody said they found that in an article as a co-administration. So again, just a nice way to kind of apply what we just went over to more of a pharmacologically based question that's probably a little bit more relevant to everyone here. Okay, are there any questions about this? Again, I didn't necessarily definitively say one versus the other. I think both would be possible. You might actually need a little bit more information about this individual to figure out what would be the most efficacious drug to prescribe to them. Okay, so our roadmap for this particular, yes, to this day, I guess. We described history, use, enzymes, the methanol, the effect on CNS, sites of action, addiction, tolerance, and dependence, effects on the endocrine system, comorbidity, as well as pharmacotherapy. Again, this is just kind of where we've been today. It's just kind of nice to see that we've hit a lot of different components in ethanol, talking about both acute and chronic use and kind of what the effects of those are. So we're going to actually switch gears here. And we're going to have to go to general. So again, we're just kind of switching gears. We've finished our conversation on alcohols. That again, I'll be putting together a study guide for the material that I have covered. I'll really be releasing it either Friday of this week or Monday of this week. I just need a little time to sit down and put that together for you. On that study guide, I'm going to be focusing on what I consider to be the important points, things that you should go back and revisit. Because this is a pharmacology class, I'm going to probably try to focus on pharmacology-based questions because I think those are the most relevant to your understanding and probably your interest, but also I think to your future education. So this will also be included in that study guide. So general anesthetics, we're going to go ahead and today talk about the history of those, the use of general anesthetics. Today we'll do an introduction on inhaled anesthetics, and then we'll move on to intravenous anesthetics tomorrow. So again, this is a very abbreviated kind of roadmap, but we'll probably kind of expand on it as we go along. Okay, so the history of it, kind of historically in terms of anesthetics. So people would really kind of do anything to dull the pain when they were exhibiting pain. So think for sedative effects. So things like cannabis, henbane, mandrake, opium poppy for the sedative effects. Now, in terms of kind of what we think as anesthesia hasn't kind of come into its full form until really the 1800s. Other physical methods that people use to kind of decrease pain and increase sedative effects for things like cold compression, nerve compression, carotid artery occlusion, and cerebral concussion. Again, these are probably not going to be the most effective sedation effects, is because there are going to be side effects to these as well, because you're also probably causing some type of damage to the body. But the first surgery under ether was in 1842, and the first general anesthesia was in 1846. So as I was kind of looking for images to associate with this, I stumbled onto this history of anesthesia. There's actually a whole webpage kind of just showing all of the history of anesthesia. So I need to switch my share screen so you can actually see this too. So again, I'm just showing you these web pages. Hopefully some of you find some level of interest in these, but this is just a history of anesthesia showing you, again, things like poppy and opium were used historically. Acupuncture is also something that has been used historically, but this is a kind of a nice synopsis of kind of, anesthesias over the ages. And so it's not really until we get down here to the 1840s, 1860s that you're starting to see actual anesthesia as we know it in its kind of common day use that we know it today that it's been used. So here you can see kind of that picture that I showed you on the previous page. Not going to be, most of the material on this website is not going to be, probably not anything on that website is going to be shown on the exam, but just a quick like, hey, this is another fun little thing to recognize. Okay, so for anesthesias, there are 5 primary effects that you want your anesthesia to have, right? You want to induce unconsciousness for an individual. It's important that if you are going to be doing any type of surgical procedure that they are unconscious for that. Amnesia, so it needs to be something that hopefully when this person wakes up from this, they don't necessarily remember what was happening during this procedure. Analgesic, so again, it should be some type of pain deadening as well, so there's not necessarily a ton of pain being felt by the individual during the surgical process. Inhibition of autonomic reflexes. We've talked extensively about the autonomic system, so hopefully this seems pretty intuitive. And then skeletal muscle relaxation. Again, you don't want to have people have any type of reflexes or other kind of, I guess, structural changes happening during any type of procedure. For an anesthesia, a very idyllic anesthesia is going to have a very quick on and a very quick off rate. So once you administer it, you want somebody to feel these 5 primary effects very quickly. And then once you cease this effect, you want it to also decrease and for someone to be able to come out of that anesthesia very quickly. Also very important is that it has a very wide margin of safety, and though because you're inducing a loss of consciousness, you don't want that loss of consciousness to be permanent, so you want to make sure that it does have that very wide margin of safety and you can bring somebody back out of it. Okay, so in terms of modern practices and how anesthesia is actually used today, it's actually generally a combination of both IV and inhaled drugs. And we're going to talk about inhaled drugs first. This is considered the balanced anesthesia technique. And so we're going to talk first about inhaled, and then we'll talk about some of the IV administered ones tomorrow. But it is determined of which specific drugs that you utilize is going to be determined by the individual that you're administering to them to, the type of diagnostic, therapeutic, or surgical intervention that the patient needs, how far under they need to go, how invasive this procedure is, how long they'll be under. And then in terms of MAC, the monitored anesthesia care, it's also called MAC, as a combination of oral or parenteral sedatives combined with local anesthetics. Now, this specific anesthesia procedure is only used in minor instances where you're having maybe some type of superficial surgery done. This is also applied when you need some type of response from the individual. And so you can think of things like maybe where you need maybe some type of invasive diagnostic procedure, but you still need to be able to respond to the individual as you're having the diagnostic done. And so this is an advantage to this particular type of anesthetic protocol, is that the person stays conscious, but you have kind of, I guess, some of those other anesthetic effects in the peripheral body. I said MAC here is monitored anesthesial care. We'll see also MAC used later on in this chapter as minimal alveolar concentration. So just make sure you keep those two straight. Okay, so I'm going to pause here for a second and see, we've kind of taken a turn into another topic. Does anybody have any questions or concerns at this time? Okay. Yeah, I'll take the so I guess, are you talking about the MAC, I assume? So the MAC, you can think of things like dental procedures. Sometimes this is used. And so we talk about invasive diagnostic procedures. So if you're having to have some type of scope in which you're not going down the esophagus, then you still have tracheal function. That's also an option in which you can utilize the MAC. But I guess probably dental procedures are an example in which this is sometimes completed. So mechanisms of action. So this is the great thing about, as a pharmacologist, reading the sentence that the mechanisms of action remain unknown, which just as a scientist drives me absolutely crazy. But what's, I guess, good about that is there are some, I guess, kind of leads as to where these actions are. It seems to kind of have a combinatorial effect at inhibitory and diminish excitation at excitatory synapses. And so you're depressing the excitatory, you're activating the inhibitory, but it doesn't seem like it's been well characterized as to exactly what receptors are binding and where. But there are some, like I said, leads that you can see here. So here, hopefully we feel very comfortable looking at the synapse. By now you've got your presynaptic neuron and your postsynaptic neuron and your action potential, and it's releasing GABA or glycine. So you have, in that case, the anesthetics that are going to be interacting here, binding things like your potassium receptor and allowing, influx of chloride. So you're potentiating essentially the negative postsynaptic response. By not allowing the potassium to flow back out of the cell, you're causing an exacerbation of that negative inhibitory response. If we look at kind of this bottom panel here, you can see that the anesthetic action is going to be at this postsynaptic neuron. We're looking at the NMDA receptor, so it's binding to the NMDA receptor and kind of not allowing the influx of that sodium or calcium into that postsynaptic receptor. So it's kind of, again, the combination that we saw very similarly to when we were looking at alcohols, where you have a up regulation of the inhibitory, a depression of the excitatory. So targets that can be included here, we've talked about chloride channels, potassium channels, some nicotinic or muscarinic receptors, AMPA receptors and NMDA receptors, those would both be glutamatergic, and then serotonin receptors as well could also be possible mechanisms of action. But again, being a scientist, this drives me a little bit nuts, but it's also a very fruitful area of research right now, kind of understanding the underlying mechanisms of this and exactly what's going on. When we look at the inhaled anesthetics, we have halothane, inoflurane, isoflurane, desoflurane, and cetoflurane. We're going to look at the structures of these compounds and then also compare their solubilities, because obviously that's going to have an important, that's going to play an important part in their the solubilities in passing the alveolar membrane and actually making it into the blood. So we'll talk about the solubilities here in a bit. The volatile anesthetics are liquid at room temperature and have to be administered using precise vaporizers. My own personal experience here is that I've done surgeries on mice and rats for neuroscience purposes. We often use isoflurane for that purposes, and so we would have those vaporizers in a cone that were very precisely kind of titrated. So we would keep the mouse or rat under so we could perform procedures often on the brains. The gaseous anesthetics are nitrous oxide and xenon, and they have a high vapor pressure and low boiling point. It's not so surprising because they're in that gaseous state. Okay. So the pharmacokinetics, essentially, since you're inhaling this, it's going to be taken up by the alveoli of the lung, and so we're going to talk about that barrier and the exchange. Again, as we talked about before, it needs to have an rapid onset and offset, being ideally. And so therefore the concentration in the central nervous system is going to have to change rapidly. I just kind of liked this particular image because it showed a summary. And so you can kind of see the evolution over time. And I guess this x-axis that you see here is the year available for clinical use. So you can kind of just see the different iterations and how, and again, how nitrous oxide was kind of the first, and ether, and then as you pass over time, kind of how those chemical structures change, possibly affecting their availability in the body. Again, I'm going to pause for a second and ask for questions. Okay. So when we're talking about this, we have to be very aware of things like inspired concentration and ventilation. So when we're talking about the ADME of these anesthetics, uptake and distribution is very important. So inspired concentration or partial pressure, I just wanted to kind of put the whole definition here because I think it makes it very clear. So it's a driving force for uptake of an inhaled anesthetic into the body is the ratio between the inspired and alveolar concentration. And so again, this inspired concentration is going to be between the inspired and alveolar concentration is going to be a huge driving force for how quickly this drug is able to go into the blood system. The partial pressure is ultimately going to be the fraction of the gas mixture. So we've got several different gases that are included in here. So in the example that's given in the text is the 70% nitrous oxide, 29% oxygen, and 1% isoflurane. So you have a combination of a couple different anesthetics there. And then to accelerate the induction, the anesthesiologist increases the inspired partial pressure to create a steeper gradient between the inspired and alveolar partial pressure. So that's how you're going to get more uptake into the system. So we ultimately are going to be looking at a bunch of graphs that show FA and FI. FA is going to be your alveolar concentration and FI is your inspired concentration. And so when we're looking at these graphs, it's important to recognize that the faster that the ratio of these two reach one, the faster the onset of action. So this graph is great because it shows you a difference in concentration. So here we see nitrous oxide at 8 liters per minute versus 2, and halothane at 8 liters per minute versus 2. And you can kind of see the differences in the onsets of action based on those difference in concentrations. So obviously, not surprisingly, the higher the concentration, the faster you're kind of reaching that effective dose. Okay. Any questions about this? Okay, so inspired concentration and ventilation. So again, this is the FI and FA is influenced by the alveolar ventilation. So it's going to be greater for inhaled with a high blood solubility. So that's part of what's going to contribute to this ratio is the blood solubility as well. So we have to look at the blood gas partition coefficient. So anything greater than 1 when we're looking at that coefficient is going to be more soluble. Okay, so let me just say that one more time. We're looking at drugs that are going to be inhaled. We're interested in solubility. That's going to essentially alter the way that drug behaves in the lung system. So your blood gas partition coefficient greater than 1 is going to be a more soluble drug. So I stated that twice, so it's probably worth kind of knowing. So this is kind of hypothetical here. So let's go ahead and look at a table kind of showing some of the different drugs that we'd be comparing. So things like nitrous oxide, desoflurane, sevoflurane, isoflurane, enoflurane, halothane. So that blood gas partition coefficient, which we just mentioned as being important predictor of solubility, you can see the numbers vary quite widely here from 0.47, 0.42, all the way up to 2.3 for halothane. So hopefully you can kind of start to surmise which of these is the most soluble. The blood-brain partition coefficient is also shown in this table. It's kind of a nice table comparing a lot of the different characteristics of these drugs. So you can see that the isoflurane has a really nice blood-brain partition coefficient. Again, that was one of the reasons we were using it when we were doing experiments on the brain, is we didn't want this drug interacting with maybe the receptors that we were studying. I explained that earlier. We looked at the MAC, but again, we'll see MAC used for the minimal alveolar concentration. And it's just kind of giving you the effective dose, I guess, of these particular drugs. And then in terms of how the body metabolizes it, it also kind of gives you a brief description of that here. This table has a nice, comment section, kind of giving you a good sense of exactly how this how and why this drug is used. So maybe a reason for choosing things like sevoflurane would be it has a rapid onset and recovery, but it is unstable and soda line. It's an interesting note. A medium rate of onset. So again, rate of onset is going to be something that's going to affect someone's choice of if they're going to use any type of any of these anesthetics. Okay, so I've been talking for a while. Good time to pause. Which of the following anesthetics has the greatest solubility? So based off of the table that you see below and what we just chatted about, which of these has the greatest solubility? So I'm just going to pause here for a second and let everybody private messenger me your answer. Okay. If you haven't responded, I'm going to give you just another moment or so to do so. Okay, so when we're talking about max and I guess the minimal alveolar concentration of inhaled anesthetics. So I pulled this up just because I thought it really had a nice graphical representation of both lipid solubility as well as potency. So looking at this particular figure, you can see that halothane has the highest lipid solubility. So if we're looking at this graph here, the way that, or this table here, the way that we'll be able to tell that is because it also has the highest blood gas partition. So the larger that blood gas partition number is, the greater the solubility that it has. So just make sure that you have that relationship clear in your mind. Just because I know there were a few of you who did respond nitrous oxide. So again, just make sure that that relationship becomes clear, where the higher the blood gas partition coefficient, the greater amount of solubility. So this halothane has the greatest amount of lipid solubility, and thus also has a higher potency. Okay, so there are some important factors that affect uptake solubility. So the blood gas partition coefficient is a useful index of solubility. The FA, if we look at these different anesthetics down here, the FA approaches F1 fastest for the least soluble agents. So this graph that also is shown in your textbook, you can see that halothane kind of has like this lower curve that you see here, and then nitrous oxide has kind of the quickest rise to that one position, and also this is kind of a nice graphical representation of where each one of those anesthetics kind of hit in their middle ground. So the question, run into your question is yes. So again, just make sure that you feel really comfortable with applying this blood gas partition to these solubility questions. We're going to be kind of continuing this conversation, talking about the different inhaled anesthetics. Will we meet tomorrow afternoon at 1 o'clock. We'll also continue talking more about general anesthetics at that time. But I guess at this point in time, I think that might be all I have for you today. Does anybody have any questions or concerns? I was just trying to keep this as close as 15 minutes as possible, so I didn't really know where we were going to end up with the alcohol talk. So does anybody have any questions or concerns about anything, about the material that we've talked about class execution, about anything? Ah, the silence. Okay, well, I was thinking, okay, yes. So someone asked really quickly. They didn't know if I was asking about solubility in the plasma or lipids. Would you specify in the exam? Yes, yes, I would. Writing confusing exam questions is not something I enjoy doing because often people get confused, don't understand the concept, and that does not benefit anyone. So yes, I would absolutely explain whether it would be plasma or lipid solubility. Yes. Okay. Well, we're finishing up 2 minutes short. It is a beautiful day out there. Please go outside, inhale some fresh air. And thank you all for your time and attention today. And I look forward to seeing all you tomorrow. Have a great day.
Thank you.